and regional anesthesia. And he is a very good speaker as well as a very good teacher. And we can see him conducting many quizzes for the postgraduates in many of the conferences. I welcome you, Dr. Balakrishna. Please proceed with your lecture, Role of Ultrasound for an Anesthesiologist. Now over you. Over to Dr. Balakrishna.
Thank you so much for that introduction, sir. It makes me humble, though I'm nothing in front of stalwarts who are there today, like Bhaskar sir, Umesh sir, yourself. So in front of all your achievements, there's nothing in front of me. And I thank this Alumni Association of our best department in the world for giving me an opportunity to once again be in front of all of you. And if you can see in my first slide, I've just put as my name and a proud VAA member, which is what my identity is for this evening. I don't share any other identity. For me, this evening, I'm a just proud VAA member. So the topic that I chose for this evening is the role of ultrasound for anesthesiologist. It will just be an overview, because if we start to talk in depth about the role of ultrasound, it's numerous and it's elaborative, and I don't think so I'll be able to cover up everything within the allotted time that is given to me. So I would like to just go to superficially about how over the years this wonderful machine has become part of our daily armamentarium of the numerous gadgets that we associate ourselves with. Our motto is part of perioperative care. We call ourselves, and even of late, the surgical associations recognize our service, and we are called the perioperative physicians. It starts from pre-op, intra-op, and post-operative period. We are part of the pain relief, which could be acute, perioperative, and post-operative pain relief, or long-term chronic palliative pain care. And all of you agree that we make the surgical procedures or any interventional procedures comfort and convenience for the patient as well as the surgeon. So this is our motto. Our procedures, till recently, maybe the time till I have done my PG from Ballari, we were taught all the skills based on landmark, or it used to be blind. Blind as in, we only know that the structure will go inside, and depending upon indirect signs, we know that we have reached our target. A very classical example being giving the spinal anesthesia, where we pass the needle at the corresponding landmark of L2, L3 or L3, L4, and we get that loss of resistance when we pierce the dura and we look for the CSF. The same way, when we put a arterial cannula, we see the gush of the blood at the skillet, and then we take out the skillet and push the sheath inside. But in the last 1 decade or so, with the gradual use of ultrasound for all our procedures, we now go by visual real-time identification of structures for confirmation of the procedures. The same procedure which a decade back or maybe 20 years back used to be done as a blind procedure, like central neuraxial blocks, nerve blocks, arterial cannulation or CVC cannulation, can now be done with the help of ultrasound machine. And of late, we have come up with very good state-of-art machines with high resolution, that doing this procedure is really a feat to the eyes and the hands. And believe me, I think all of you will agree that if you have done the ultrasound guided procedure the whole day, it gives you a satisfaction and happiness. What are the advantages of ultrasound machine? It helps in real-time visualization. There is no risk of ionizing radiation. It is non-invasive, so better patient and surgeon's compliance, because the surgeon will be little bit hesitant or apprehensive when we use the machine to do any kind of a procedure, or when we use a new gadget on the patient, because usually a patient comes for a surgeon. So this being a non-invasive or maybe semi-invasive, as we use it for doing ultrasound guided procedure, the compliance is better. And with the advent of color Doppler, it helps in differentiating flow minute structure. A classical example being to differentiate between a artery versus a vein. Where do we get to use this equipment? and ultrasound guided skills, mainly for nerve blocks, which was the first thing where we started using. And of late, we have started using it for the airway assessment to look for the abnormality or anomalies in the airway, central venous cannulations, ultrasound guided arterial cannulations, in aiding central neuraxial blocks, fast scans in emergency, and many more. Before we go about where actually we get to use the ultrasound machine, let's get a few basic facts of the machine and the probe with the help of a few slides. Whenever we talk about any person or any equipment, we must always remember the history as to our peers, forefathers, or ancestors, how much they struggled to get things developed. During those days, it was very, very difficult. The equipments are cumbersome, they worked a lot, and the history of ultrasound machine is something very similar to that. It all the way goes back to the year 1877 when Lord Rayleigh first introduced the theory of sound, which put the first foundation. Then in the year 1880, Pierce and Jacques came up with the piezoelectric effect. Then in 1942, Ducey came up with the first ultrasound machine for medicine. In 1970, the grayscale came up, and in the year 1980, the revolutionary color Doppler effect was incorporated. Usually, the frequency what we get to see in ultrasound machine is more than 2 megahertz. So that is the reason it is called as ultrasound, which is something higher than what we are able to hear. And this image is a classic visualization of how a machine appears. So this is a ultrasound machine with casters, and there is a screen, buttons, and you get to see the different probes, which is magnified in this particular image. Most commonly, what we get to use is the straight probe and the curvilinear probe, and sometimes the echo probe to visualize the cardiac chambers. So how does ultrasound machine work? So there is a transducer which emits high frequency sound waves, and these are transmitted to the tissues. Depending upon the tissue consistency and the qualities, these sound waves will either be absorbed or reflected or refracted. The reflected sound waves are then picked up by the transducer, which then converts it into an image with the help of specialized software, which we are able to visualize, and we are able to make out the structure what actually the machine is scanning. Depending upon the sound reflectance, for example, bones, fats, and any kind of stones like gallstones or renal stones, they produce a hyperechoic signal. What is this hyperechoic signal? I shall show in the subsequent slides. These objects appear as bright as most of the ultrasound machines are reflected because these are solid consistency, so they do not absorb the ultrasound waves. Cartilage and muscles produce hypoechoic signal, and these appear dark as most of the waves will pass through the tissue with some white specks in between. And the last are the fluid and fluid filled structures, like for example, the artery, the vein, or if there are any fluid accumulated in the third space. So these appear as anechoic signal. That's the reason we use color Doppler to identify between an artery and a vein, because both appears jet black. So they appear black as there is no reflection of even minuscule of the ultrasound waves. So as I mentioned earlier, we use different types of the probes. So this is a linear probe or the straight probe, which has frequencies of anywhere between 7 to 15 megahertz. It is high resolution, and it is usually used to identify the superficial structures. For example, the vascular access or the nerve blocks. And then we have the curvilinear probe. Most of the time this is used by the radiologist. It is of low frequency and low resolution, but helps in assessment of the greater depth. Now recently we have come up with many numerous ultrasound guided blocks where we use the deep probes like the Peng block, the TAP block. So all these use the curvilinear probe. It is usually useful for abdominal, pelvic, and obstetric examinations along with deep lung tissues. And then we have the phased array probe, which is the lowest frequency. It is useful for the echocardiography. So this slide shows how an image is generated when ultrasound beam passes through the tissue. The tissues reflect back the image and what we get on the screen. So this is the image that is seen when we use the straight probe. This is the image that we get to see when we use a curvilinear probe, and this is the phased array probe, usually used to visualize the cardiac. And what we see, this is called the footprint span. This is the footprint span of a linear probe. This is the footprint span of a curvilinear probe, and this is the footprint span of a phased array probe. This graph is self-explanatory. It shows that as the frequency increases, that is from a curvilinear to a linear, the resolution increases, but the penetration decreases. So that's the reason. On the basis of this graph, we see that when the frequency increases, the penetration reduces. So that is where we get to use the linear probe. And as and when the frequency reduces, the resolution increases and the depth increases. So we get to use the curvilinear probe, which is somewhere between 2 to 5 megahertz, to visualize the deeper structures. And this is how we are supposed to hold a probe. This is how we hold a straight probe, and this is how we hold a curvilinear probe. It all comes with experience. If you are able to hold the probe gently and in a systematic manner, you will be able to scan the tissues better, and you will be able to perform the procedure much better. If somewhere you try to hold the probe near the neck, there are always chances that the connection might get loosened, the wires might get disconnected, and eventually the probe will get damaged. So this slide is about the basic movements, the cardinal transducer movements. So if you see in the first one, this is called the sliding movement, where we hold the probe straight without twisting it, and we tend to move it back and forth and side to side movement. So this is 4 directions. Here I would like to stress a point that we must always apply a liquid or a jelly. Sterile liquid could be anything like your chlorhexidine or jelly, sterile jelly, because most of the time we do the ultrasound guided procedures in an aseptic manner. And in one of the workshops, I remember one of the experts telling that spirit must never be applied to the place where the ultrasound beam is generated, because it damages the piezoelectric crystals and the image quality gets worsened. I might be wrong, so I think if the experts are there, they might correct me or add a word about this, because there are conflicting evidences. The radiologist mentioned that spirit or sterilium can be applied for the transducer to improve the image quality, but personally I don't do it, because I'm of the fear that if the probe gets damaged, then we can't do any procedure. So this is the sliding moment. This is the tilting moment. You maintain in the same position, but just gently tilt. This is especially required when you're doing a nerve block and you're doing an out of plane approach, or you're doing a out of plane central venous cannulation. So this range of movement comes, and then you're going to keep the probe in the same, but try to rotate it along the same axis. And then this is the rocking moment. So these are the range in which you are going to do the movement and try to identify the structure of interest. So with these few slides on the basic of ultrasound machine, the probe, how does they work, and how are we supposed to hold a probe, let us see a few applications. I'm just going to share a few slides, a few images of where exactly we get to use the ultrasound machine, and I'm not going to describe everything in detail because it is time consuming, it is elaborate, and we can always discuss when we get adequate opportunity. So the first application of ultrasound machine is for the nerve block. As we can see in this particular image, that this consultant is using the straight probe to perform a supraclavicular brachial plexus block. So if you can see in this particular slide, as I was mentioning earlier, what is meant by hyperechoic, what is meant by hypoechoic, and what is meant by anechoic. If you can appreciate this particular line, now this is the image of a supraclavicular brachial plexus block. So this line, what I am highlighting, is the first rib, as you can see in the next picture. So first, this is a blind image, and then this is the anatomy. So this is supposed to be a hyperechoic structure because this is a bone and it does not absorb any radiation, as in it does not absorb any ultrasound wave and it reflects. So it is a hyperechoic. What we see here, this is the subcutaneous tissue. It is hypoechoic. These are the muscles, and especially the fascia. They seem to be hypoechoic because they partly absorb and partly reflect. And what we get to see, this is what is your supraclavicular brachial plexus. If you can see here, it is yellow colored, is highlighted, and this is the subclavian artery. So blood is flowing in this. Now blood is a liquid, so that's the reason you get a anechoic image. So I hope you are able to differentiate between a hyperechoic first rib, a hypoechoic muscles, and then a anechoic fluid, that is the blood which is present in the subclavian artery. So this is yet again an example of a hypoechoic image. This is actually the local anesthetic which is spread, and this is the needle path. What we usually do, the needle, if you can see the longitudinal length, then that becomes an in-plane approach. But if your needle appears like a dot, that's called an out-of-plane approach. Most of the time, it is preferable to do an in-plane approach because we know exactly where the needle tip is. So it is always advisable that till you are able to visualize the needle tip, never ever inject any local anesthetic, never ever inject any medication, or never ever do your CVC or arterial cannulation procedure. Because sometimes if you're going out of plane, what is appearing as a dot might actually be the shaft and not the tip. So accidentally, if your needle tip is inside a vessel and you're not able to visualize and you end up injecting the drug, that could be one of the reasons for local anesthetic intravascular administration and toxicity. So this is a femoral nerve zonoanatomy. So here we use the femoral nerve block. So as you know that this is the femoral vein, femoral artery, and what you can see here on the iliopsoas, this is the femoral nerve. You can make out the difference between artery and a vein with the help of color Doppler, which helps in identifying the waves. And one more thing is the pulsatility. If it is pulsating, it is an artery, and if it is not pulsating, it is a vein. Now, pulsation can be made out even without the help of your Doppler mode. And one more that helps us to differentiate between an artery and a vein is the probe compressibility. If we use a linear probe, if you compress on the structures, because these are superficial structures, so we cannot use a deep probe. If you use a superficial probe and you press, a vein will get compressed because its walls are more elastic, but an artery will not get compressed because the adventitia is relatively thicker. So these are the three ways in which you can differentiate an artery and a vein. First thing is the pulsatility. An artery pulsates while a vein will never pulsate. Second thing is the compressibility. A vein gets compressed, an artery does not get compressed. And third difference is that with the help of a color Doppler, you can see that an artery appears red because the blood moves away, and the vein appears blue because the blood moves towards the probe. This is the ergonomics of a brachial plexus axillary block, which most commonly are done by beginners. So this is the ergonomic where we keep the upper lip abducted and the person stands right beside the patient and the screen must be facing the anesthesiologist. So here we get to see in this image that this is the axillary artery and all this yellow color mark thing are the nerves. This happens to be your median nerve at 11 o'clock position. This is your ulnar nerve at 2 o'clock position. This is your radial nerve and this is your musculocutaneous nerve. Now this could be hypoechoic. One way to identify your musculocutaneous nerve is it is one of the nerves in the body which is hyperechoic because it's got multiple facial coverings and it usually is in between the muscle substance and in a few cases in between the facial planes which separates your coracobrachialis and the biceps. So that helps in differentiating your musculocutaneous and all the other nerves. So this is the needle approach. This is the anterior and this is the posterior. And in this way, you pass the needle, you'll be able to block the median nerve and ulnar. You pass it below the axillary artery, you'll be able to block the radial. And then you go down, you'll be able to block the musculocutaneous nerve. And this is what is seen, the local anesthetic spread around the nerve. One particular advantage of using ultrasound guided nerve blocks is that it has helped in reducing the total volume of local anesthetic which we used when we perform blind procedure. During my initial days of anesthesia practice, I remember I used to use up to 40 ml for a supraclavicular blind approach and for axillary up to 50 ml. But now with the advent of ultrasound with good visibility, I have reduced the volume for axillary brachial plexus block to up to 20 ml and for supraclavicular up to 15 ml. So it is almost reduced by more than 50%. So if you are able to reduce the dose of local anesthetic with the same quality of action, ultrasound definitely scores over your blind procedure. But here I would like to always mention that blind procedure has its own essence. We must be familiar with the gadgets, but then we should never forget how we started doing our procedures because machine has got one limitation. If it gets spoiled, it's gone. Till it gets repaired, you cannot do the procedure. And if you are a person who is always habituated to machine, then you may have to stop practice because your entire anesthetic procedure is dependent on machine. But if you're familiar with blind procedures, no one can stop you from doing your central neuraxial blockade, cannulation of the great veins, arterial cannulation, nerve blocks, because you are equally familiar with the blind approach. So this image is about the internal jugular vein zone anatomy. This is the carotid artery, this is the jugular vein, and I told you in the earlier slide how we can differentiate between the artery and the vein. This is the interscalene approach for the brachial plexus. It almost resembles the same anatomy, and these are the trunks of your brachial plexus. We usually pass the CVC needle from lateral to medial through this approach. This is your sternocleidomastoid, and once we are able to see the tip inside, then we put the guide wire, we dilate it, and we put the catheter. This is the use of the ultrasound machine for arterial cannulation. As you can see here that the consultant is using a straight probe, and what approach she is using is a curvilinear approach. Here it is going to cut the beam. If it is a linear, you can see the entire structure along the length. Here it is going to cut the beam, and this is what it appears. This is the radial artery, and your needle will start appearing as a dot if you are using a curvilinear approach, and if you are using a linear approach, it will appear as a straight, the tip as well as the shaft, and once it is inside, you will see the flash of the blood, and then you can cannulate. So this is a very revolutionary development where we have started using ultrasound for cannulation of veins as well as the artery. And for central neuraxial block, we can always say that it is ultrasound aided and it is not guided. Sometimes it helps in guiding, but most of the time it helps us in visualization of the sonoanatomy of the spine, because especially in the elderly people where there is calcification of the spine, sometimes if we go by the blind approach, I hope most of the consultants will agree with me that putting a spinal needle or epidural needle in obese, in elderly patient, could sometimes be challenging because of the calcification, the abnormality in the anatomy. The guy who is giving us a position may not be competent enough, and so we end up pricking multiple times, and sometimes the patient might get really restless. So in such cases, we can use an ultrasound probe and assess the anatomy. So this is the transverse spinous process anatomy. So we can see that this is the anterior complex, this is the posterior complex, and this is the vertebral canal, and these are the paravertebral muscles. This is the erector spinae. That was the spinous this one area. This is the interlaminar zone anatomy. If you can see here, we can make out this is without the color and this is with color. You can make out that this is the spinous process, this is the anterior complex, this is the posterior complex. So especially we can make out the interlaminar area, which is the best, and we can decide at what level we will be comfortable putting the epidural, the spinal, and sometimes even the paravertebral blocks can be done by doing a scout scanning of the midline as well as the paravertebral areas. The fourth area where we use gastric ultrasound is to quantify and confirm whether the patient is fasting or not. We most of the time come across patient who may not be giving us the right history of when did exactly he have the last meal. So then he would have had some lunch or some snacks and told that he or she wouldn't have had anything in the last 6 hours. And when you end up giving GA, they might regurgitate, only then you know that their stomach was not empty. So with the help of a curvilinear probe, keeping the patient in the right lateral position and scanning the epigastric and hypogastric region, you will be able to generate an image. So this is the gastric antrum, which is empty. This is the liver, and these are the abdominal muscles. This image will be generated when you use a curvilinear probe. This is the aorta. So this is the antrum which is empty. If you get this image, it confirms with the history that the patient is fasting. And by taking cut section, the width and the length, and by using the Perla's formula, you will be able to come across a volume which most of the time matches with the patient's fasting gastric content. And ideally the fasting gastric acid content is 1.5 ml into patient's body weight. So that anatomy, that formula can be used to quantify how much is the patient's fasting gastric volume. So we have done a paper in which we use the fasting gastric volume between diabetic and non-diabetic, and found that the fasting gastric volume in diabetics were significantly higher compared to the non-diabetic with the use of the gastric ultrasonography. This is what we get when we do the gastric ultrasonography in a patient who has consumed water. So this is the clear fluid, and what you can see here, these are the bubbles which reflects the light. This classically is described as a starry sky appearance. If you get this image, you know that the patient has consumed water somewhere in the last 2 or 3 hours. So it might be an indication to do a rapid sequence induction. What you're getting to see, this is the inferior vena cava, and this is the superior mesenteric vein. This is the liver. And what you get to see, this cheesy pattern, is when you have consumed solids, especially which is oil rich. So then what you get to see, this is the cheesy pattern. If you get this particular kind of an image, until and unless it is a genuine emergency, please do not go to give general anesthetic. You might end up with regurgitation and aspiration, which can sometimes be very fatal, as you all will agree that regurgitation and aspiration of solid contents are much more fatal than liquid. And what you're seeing, this is the aorta. And then the fifth indication of ultrasound is in mapping the airway. So you can see here, this is the air mucosal interface. This is the cricoid cartilage, and these are the strap muscles. This is the image that is seen in a cross section of cricothyroid membrane transverse anatomy. This is the trachea, and this is the longitudinal section or the sagittal section. So this image can be used to do a emergency cricothyroidotomy in case of a difficult intubation or complete ventilator failure, as mentioned in our AIDA guidelines. So that time, this string of pearls appearance comes when you keep the linear probe in a sagittal plane. All these are the tracheal cartilages, and this is your thyroid cartilage. This is the cricothyroid membrane, and this is your trachea. This is the lung ultrasound, which is the sixth application. Most of the time, this application comes in the ICU, where we get to diagnose whether the patient has got pneumonia, pleural effusion, or pulmonary edema. What you can see, this is the A line. This is classically seen. And this is the pleura. This horizontal line, whatever you can see, is the A line. If you get to see this B line, this is not something physiological, it is pathological. It helps you to see that some amount of liquid is there in the lung parenchyma. Now, you don't know whether it is pulmonary edema or whether it is pneumonia, but it definitely shows you that there is something abnormal. And then this is the classic lung sliding sign that we get to see in the 2D echo. If you get to see this image, this is a typical seashore sign. If this is there, the lungs are normal. Unlike if you get this type, the barcode image, it might mention that it is absent lung sliding sign, and there is something abnormal. It can be pleurisy, or that can be pleural effusion. So all these indirect evidences can be picked up by lung ultrasonography. So what we get to see in this image is a diagnostic screening. IVC stands for inferior vena cava. Of late, the use of ultrasound machine has been to check for the diameter of the inferior vena cava and quantify whether the patient is hypovolemic, and if so, whether they respond to fluid challenge. We usually get to see the diameter of the IVC, and this is how the probe is kept. We use a curvilinear probe below the costal cartilage till we get the image of this. It is the inferior vena cava that is posterior to the liver. You have to see the initial diameter, and if it is less, give a fluid bolus and look for the change. If it improves and if the BP also improves, that means that this hypovolemia is responding to your fluid challenge and helps in correlating that the hypotension is because of hypovolemia. However, if it is not responding, that means that the hypotension or the hypotensive shock is something more than your hypovolemia. So then you may have to start the patient on inotropes or vasopressor. What we get to see, this black structure is the hepatic vein. And of late, FAST scan has emerged as yet another application for looking at the blunt injuries and looking for the collection. Now it's an emergency diagnostic or screening scan. It assesses for fluid or blood collection in the 4 dependent abdominal regions and helps in clinical correlation or quick action plan. There especially the hepatorenal fossa, the subxiphoid view, the left upper quadrant, and the pelvis. Hepatorenal fossa to look for collection in the hepatorenal space, the subxiphoid to look for the pericardial fluid, the left quadrant to detect fluid in the perisplenic area, and the pelvis to look for fluid in the pouch of Douglas. As I mentioned earlier, this is only a diagnostic, and it has to be correlated with other diagnostic imaging and other clinical time, because we cannot consider this as the diagnostic. It only aids in diagnosis. So this is the image of a heart scan where the hepatorenal fossa is scanned to look for fluid in the hepatorenal space. So this is your hepatorenal space. This is the subxiphoid view to find any fluid in the pericardial region. This is the left upper quadrant view to detect the periclinic area. So this is the spleen and this is your periclinic area. And then this is the pelvis where we get to see the fluid in the pouch of Douglas. Apart from this, there are other uses of ultrasound machines like transthoracic echo or transesophageal echo, if at all there is any CABG going on, or to diagnose major pulmonary embolus, and it can also be used to diagnose increase in the intracranial pressure by looking for papillary edema. So we can see that of late, with the advent of time, that the use of ultrasound machine has diversified for diagnostic, therapeutic, and to correlate with other diagnostic aids. So these are a few references for my talk, and once again I would like to thank the organizers of this event, the great anesthesia department of Vijayanagar Institute of Medical Science, from where I did my PG, and I always tell everyone that I'm a proud member of this department, and I thank once again for giving me an opportunity for being part of today's evening program. Thank you so much.
Thank you, Balakrishna, for your excellent presentation. We'll just take a question, if any. Sir, Bhaskar sir, you want to? Yes.
Yeah, it's a very precise and focused presentation by Balakrishna.
Thank
In
you,
fact,
sir.
that will be enough, especially for a beginner who is trying to get hold of an ultrasound. So he has expressed about what is meant by ultrasound in terms of the frequency of the sound, then how the probe is to be used, how the probe is to be maintained, and he has spoken about the appearances, co-appearances in terms of anechoic or hyperechoic or hypoechoic in a sequence. Why I am trying to tell is this is actually perfectly in sequence, and the appearances of the echo in the usual practice, starting from our peripheral nerve blocks to the vascular cannulations to the cardiac uses and the cardiovascular uses, of course, ultrasound of the airway and gastric ultrasound. So I must congratulate Balakrishna. Definitely, it's a useful presentation. And more, that's what, again, I'm repeating, it's within the 30 to 35 minutes. It has been an excellent, concise presentation. Any of the juniors have got any doubts about ultrasound?
We will take views from Umesh sir. Umesh sir is there.
Umesh sir is there?
Yeah, let him also comment.
Yes,
Yes, sir. Yeah.
Yeah, it was a wonderful presentation from Dr. Balakrishna, as expected, actually. I mean, he's so good at simplifying things. Hello?
Thank you, sir. Thank you so much.
Yeah. You have really simplified the topic so beautifully that you have covered the basics of the ultrasound machine.